Guys, today we are going to discuss the topic of adult bradycardia algorithm. Okay, so this is one important topic which I'd like to discuss because basically I faced a patient recently who had this bradycardia, and we couldn't save the patient, but we tried this algorithm. So that's why I want to discuss it with you today. So basically, before discussing about this topic, this condition usually occurs. What is it? To patients who are in shock. Okay, who are like literally in many. There are many types of shock. Like cardiogenic, hypovolemic. So I faced this patient recently, and was at emergency center. Okay, so but you couldn't save this patient. So first, when we talk about this adult bradycardia, see, whenever we are in emergency care, we see many patients coming. People may come with road traffic accidents, might be in DKA, which is nothing but diabetic ketoacidosis, in shock. Okay, so but whenever usually when what is that our professors or when our what is it, madam says about PGs, when they say about shock, what everyone would remember as in when like we are in internship at the time, what everyone used to remember is that shock means it's nothing but hypovolemic shock. Okay, that's what we usually remember. So what I used to do, I used to when ma'am says like anyone like they are in shock, I used to see the BP. Okay, I used to see the BP, and like if the BP is low, first what will you do? Like okay, go and put lot of fluids. Okay, intravenous fluids you used to give it. So at that time we never you usually, okay, anyone for that sake, no, we don't care about the pulse rate. Okay, everyone knows that there are many types of pulse rate. We'll be discussing that also. Like pulses alternance, pulses bispherians. Okay, there are quite a lot of pulses, and there is a graph to understand that also. Okay, we'll be discussing that also. But what I wanted to say is we usually don't see this pulse rate, right? Okay, so we used to forget what is this. Okay, we have to monitor the pulse rate. We usually don't see that, and many times, okay, we consider that as insignificant. Okay, so today we are going to discuss this, okay, topic, okay, about this normal what is it, how to manage this patients with bradycardia. Okay, so sometimes many patients know doctors know how to manage the patients with tachycardia also, but bradycardia many people, okay, they usually forget. So that, okay, normal pulse rate is 60 to 100. Okay, its normal pulse rate is 60 to 100 beats per minute. Okay, we know that. And what American Heart Association guidelines say, that recent they have updated, is that even, okay, 60 beats per minute, okay, we can just leave it, or 50 to 60 also we can. Okay, it's not required to do any particular intervention, but when it becomes less than 50 beats per minute, there is a time to start the intervention. Okay, so when a patient is less than 50 beats per minute, we can consider them as bradycardic patient, and we can start. Okay, we have to start the treatment immediately. Okay, so that is the thing. So let's see the flow chart. Okay, what has been given, let's discuss it. Okay, see, okay, so when the persistent bradycardia, it might be, okay, due to many things. Okay, it might cause many things, it might cause many complications, so let's discuss that. See, persistent bradycardia may cause the following things. Okay, let's see what are those. Okay, it might, the persistent bradycardia can also cause hypotension. Okay, can cause hypotension, can cause, so you can cause Altered mental status. Okay, altered mental status. That is acutely. Okay, it will cause altered mental status acutely, and there will be signs of shock. Okay, there will be signs of shock. Okay, next there will be discomfort. So we might consider it as what is it, MI? But this bradycardia can also cause this. Okay, usually we always think about tachycardia, no? Like ventricular arrhythmias, we might think like that. But bradycardia is also one important thing. So it might cause ischemic chest discomfort. Okay, so and last it might also cause acute heart failure. Okay, so these are the complications which causes this. Okay, it might cause hypotension, it might cause altered mental status, it might cause signs of shock, and it might cause ischemic chest discomfort, and nothing. And last but not the least, it might also cause acute heart failure. Okay, these are the things it can cause. So now, when a patient comes to you, okay, with these conditions, okay, with bradycardia, so what we are going to do? Okay, it's also called as like bradyarrhythmia. Okay, so when a patient comes with this, what are you going to do? Okay, what I said in the beginning, no, always what we'll think. Okay, we'll put a line, we'll put a IV line, okay, and we'll start them with a lot of fluids, right? We'll put a IV line, we'll start them with a lot of fluids. Okay, as we saw that if the patient, provided the patient is in hypotension, right? Okay, and you should also see, I need not say that, but you should also see whether the patient is an MI patient, so that we have to monitor the fluid, what's that, infusion properly. Okay, that is also there, but generally we do it first, no? So what can we do? Is this enough? So that is my only question. Okay, is this enough, or you have to do any you have to give any particular drug? So that is the thing. Everyone knows, like in tachycardia, everyone would have heard that adrenaline is commonly given, right? Everyone, most of the people know that adrenaline is commonly given. But what about this bradyarrhythmia? So see the last page, what we saw, no? If there is persistent bradyarrhythmia, okay, and it is causing bradyarrhythmia, okay, so and it's causing the symptoms. Okay, it's causing those symptoms what we discussed, like hypotension, heart failure, acute heart failure. So if these things and signs of shock, if these things happen, what we have to do? So the next thing is, if it is not present, okay, just bradycardia is present but no symptoms are present, and it's not persistent in nature, we can just monitor. Okay, if it's not there, we can just simply monitor. Okay, see, if it's not present, what we can do is nothing but monitor and observe. Okay, right? So if a patient comes and you check his pulse or her pulse, and you see that it is very less, okay, it's just 40 or it's just 50, so immediately you should not start the patient with fluids or anything. You have to wait for some 10 minutes, ask them to consume some oral fluids, and then drink some oral fluids and check again. Okay, so that is what we are going to do. But if that bradycardia, if that heart rate is still below 50 beats per minute, it is constantly and persistently less than 50 beats per minute, and if you see the patients with some kind of discomfort, and the signs which we discussed, like hypertension, the BP is also low. So what we are going to do is, we are going to start the patient with something called as atropine, right? Yes. So what we are going to do, if these symptoms are present, we are going to, if these symptoms are present, we are going to start the patient with something called as, I'll write in a different color, okay, maybe pink, yeah. Okay, we are going to start the patient with atropine, right? What is atropine? Atropine is an anticholinergic agent, you know that, right? It's an anticholinergic agent. Okay, so what is the dose? First we give 1 milligram bolus. Okay, we give 1 milligram bolus and repeat it for every 3 to 5 minutes. It's not like 1 milligram bolus and you just forget what has happened to the patient. It's like repeat it every 3 to 5 minutes if the patient doesn't recover. Okay, so after 1 milligram bolus, you have to repeat it every 3 to 5 minutes. So what is the maximum dose? Can we give like 10 mg? No. So the maximum dose that can be given is 3 mg. So how many times can you repeat it? Maximum 3 times only. So within 15 minutes, you have to administer 3 mg if the patient doesn't recover. Okay, so that is the first thing we'll do. What is the next thing? After atropine, is there anything we can do? If still the patient presents with same condition, if the patient still presents with bradycardia after atropine, what we are going to do is, we have given the maximum dose of 3 mg. Okay, so at this time, what you can do, if this atropine is ineffective, okay, if atropine is ineffective, what you can do is you can do transcutaneous pacing. Okay, transcutaneous pacing. See, you get transcutaneous pacing, or if these are not available in a hospital, what you can do is dopamine infusion. Then only you have to go for something called as dopamine infusion. Okay, even if you are working in like primary health centers or any rural areas, even if there is a dopamine supply has been, it has got over. Okay, what you are going to do, everyone will have all of your favorite, what is that, epinephrine infusion. It's not like bolus dose. It's not like something which we given tachycardia, no. It's not like something bolus dose. It's like epinephrine infusion. Okay, that's what you are going to give. Okay, so if that is also ineffective, what are you going to do? Okay, you give that atropine, you reach the maximum dose of atropine. Even at that time, after that, after giving transcutaneous pacing or dopamine infusion or epinephrine infusion, if that is also ineffective, what you are going to do? See, if that is ineffective, what you are going to do is consider transvenous pacing. Okay, we are going to do something called as transvenous pacing. Okay, and consider referring to, if that is not available, then consider referring to higher centers or expert consultation. If you cannot shift the patient, obviously you cannot shift the patient means you have to call over experts, specialists. But if we can shift, it will be far better. Okay, consider expert consultation. Okay, so what we saw here is this adult bradycardia algorithm. Okay, I hear that many people will be in doubt, but what is this transcutaneous pacing or transvenous pacing. Okay, what is this? What is this transcutaneous pacing? What are you going to do? How to do it? Okay, so we'll discuss about that in detail later. Okay, I think people you'd have heard about pacing. It's just a brief I want to say. It's like pacing, synchronized cardioversion. Everyone will be no. It what does it do? It synchronizes in the same way. This transcutaneous pacing will pace. Okay, the heart. The heart rate will come into normal thing. That there is many things to discuss about that, which we'll discuss later. So after if transcutaneous spacing doesn't work out, we can shift to transvenous spacing, right? Okay. So let's just see this algorithm. Okay. So if a patient comes to you with bradycardia, okay, there is nothing but less than 50 beats per minute, and it is persistent. Okay, if it is persistent, just I'll write it properly. Less than 50 beats per minute, and if it is persistent, what you are going to do, we will consider the patient as a bradycardic patient, and next we will see for what is it, signs and complications. There is hypotension, altered mental status, if they are present acutely, signs of shock, okay, ischemic chest discomfort, acute heart failure. If these things are there, then what we are going to do is we are going to consider this following algorithm. That is, if there is persistent bradyarrhythmia and if present with hypotension, acute heart failure, shock, means if it is just for one or two occasions, like you first measure the pulse rate, if it's less than 50 beats per minute, then you monitor again, okay, again, at least for like 2 to 3 occasions. If it is the same persistent, or like patient attender may say like from morning they are like very drowsy, they are very tired, they are very fatigued. Okay, at that time you can consider this algorithm. After measuring, confirming with your palpatory method, like even while measuring BP, you can see the pulse rate. Of course, we always confirm by palpatory method, but I'm saying like more than 2 to 3 occasions. Then you see that they are presenting with hypotension and stuff. Okay, with this color it will go off. Okay, just 1 second. I'll use another color. Okay, see like hypotension or shock or acute heart failure. At that time, if it is yes, then you can choose to give atropine. Okay, what will be the dose of atropine? First, initially it is 1 milligram bolus. Okay, it is 1 milligram bolus. That's what you have to remember. And how much atropine we can give? We can repeat it for every 5 minutes. Okay, every 5 minutes. And maximum number of times you can give is 3 times, right? So maximum the dose we can give is 3 milligram, right? Okay, next. But even after atropine, the patient doesn't recover. If it is ineffective, we go for something called as transcutaneous pacing. Okay, we go for something called as transcutaneous pacing. Or if transcutaneous pacing is not available in your center, you can go for dopamine infusion, right? You can go for dopamine infusion, or what we have is epinephrine infusion. Okay, so then at the last, if that is also ineffective, you can go for transvenous pacing. Okay, so these are the things. So this adult bradycardia algorithm is one important algorithm that everyone needs to know, because like in our hospitals we usually see patients with tachycardia. Okay, bradycardia is very less, so this is one important algorithm which we have to learn. So I think this would be useful for you. So please do revise this, and just don't forget this algorithm. Okay, and while also you're practicing in emergency, please do practically apply it. Okay, so it's so important in saving the life of the patient. And atropine, what is it? And I want to ask this question: what is atropine? It is an anticholinergic agent. Okay, so remember that also. So thank you guys. So have a good day. Thank you. We can meet in a new video soon. Thank you. Bye.